In this lecture, we will be discussing some of the more frequently used approaches to intraventricular tumors of the lateral and third ventricles, as well as commonly cited advantages and disadvantages. When choosing an approach to the ventricles, it is important to consider the following: local tumor anatomy, such as exophytic regions or areas of invasion; hemispheric dominance; vascular anatomy, especially venous anatomy; existing neurologic deficits, if any; and surgeon and operating staff experience with a particular approach. We'll start with approaches to the third ventricle. When creating these tables, we chose to characterize approaches grossly by the direction of approach, indicated by the far left column. The farthest left column indicates the gross directionality of the approach. The second column describes how the surgeon will approach the ventricle from a regional anatomic perspective. Ultimately, some parenchyma must be transgressed in nearly every approach to the ventricle. The third column describes the specific structure that will be involved to enter the ventricle. Here we will discuss some of the most commonly used approaches, starting with the lateral ventricles. The intrahemispheric approach is a versatile midline approach typically used for resection of midline lesions. It offers excellent access to lesions of the frontal horns, body, and atria of the lateral ventricles, as well as the third ventricle. One of the primary advantages of this approach is that it avoids the need for cortical transgression. Unfortunately, lesions that are further off of midline can be difficult to reach and may require additional cerebral retraction or a contralateral approach to improve the working angle. For entry into the lateral ventricle, a corpus callosotomy is performed to create a window into the ventricle. Special attention must be paid to avoid injury to the bilateral cingular gyri, anterior cerebral arteries, and any bridging veins to the sagittal sinus. Although we do everything possible to avoid sacrificing draining veins in all of our cases, the effects of a venous injury to veins draining into the anterior sagittal sinus are typically of less consequence compared to damaging veins that drain the posterior frontal or parietal lobes. The transfrontal approach is another commonly used approach to lesions of the frontal horn or body of the lateral ventricle. It is a transcortical approach carrying a hypothetical increased risk of postoperative seizures, although this risk remains indeterminate in the current literature. One of the key advantages of this approach over midline approaches is that it provides the surgeon access to the lateral aspect of the ventricle and the line of sight trajectory to lesions extending into the contralateral or third ventricle. In addition, passing through the superior frontal sulcus or middle frontal gyrus avoids damaging bridging veins to the superior sagittal sinus. If the corticectomy is made too far posterior, especially on the dominant hemisphere, the patient may develop an unexpected supplementary motor area syndrome. This is a rare complication that can be avoided using neuronavigation, measurements, and intraoperative landmarks such as the coronal suture. The transparietal approach is another transcortical approach that mainly is used to access the ventricular atrium, as well as the body, temporal, and occipital horns of the lateral ventricle in proximity to the atrium. This approach can be particularly helpful for resecting choroid plexus tumors and, depending on tumor anatomy, may allow for early identification and ligation of choroidal artery pedicles, as long as the tumor isn't directly blocking access to these feeders. The transparietal approach is typically performed through the superior parietal lobule or intraparietal sulcus to avoid damaging language and visuospatial function that is typically represented cortically by the supramarginal or angular gyri and their underlying networks. Parietal syndromes can be equally, if not more, debilitating than motor deficits and should not be taken lightly. The transtemporal approach through the middle or inferior temporal gyrus to the temporal horn is a workhorse approach that is commonly used. Risks are primarily to Meyer's loop and receptive cortical language, or the arteria fasciculus, both having some representation in the posterior superior temporal gyrus. These issues can typically be avoided if a corticectomy is made in the middle or inferior temporal gyri, especially if made anterior to Heschel's gyrus. Tumors in this ventricle will typically receive their blood supply from the anterior choroidal artery, which enters at the plexal point of the choroid fissure. If the tumor can be readily manipulated or mobilized, this allows vascular pedicles arising from the anterior choroidal artery to be sought out and cauterized to reduce tumor vascularity. The third ventricle, located deeper in the brain, adds an additional layer of complexity to the approaches to the lateral ventricles and portends a significantly longer reach requiring longer instruments and narrower corridors with additional blind spots. Equipment such as the rigid endoscope may be incredibly helpful for aiding in third ventricular tumor resection. The midline interhemispheric and lateral transfrontal approaches to the third ventricle share the same risks and benefits as when used to approach the lateral ventricles. However, once inside the lateral ventricle, a new set of decisions must be made in regards to how to open into the third ventricle. For small lesions centered around the foramen Monro, such as a colloid cyst, the transforaminal approach through the natural orifice of the foramen Monro may suffice. However, by limiting the opening, there is the possibility of an increased risk of phonoceal injury. An incision can be made posterior to the foramen Monro and extended into the choroidal fissure to allow for more expansive working space. This can be performed through either a transchoroidal or a subchoroidal approach, which differ primarily in the location of the incision to enter the third ventricle. The inherent risks of such an approach are related to the local venous anatomy and the fornix, as shown. The lamina terminalis can be approached and opened from a directly anterior or lateral trajectory using a subfrontal or cranioorbital approach. Lateral approaches often provide more flexibility resecting tumor beneath the chiasm, but can be more limited in accessing the posterior third ventricle. There are also advantages of working across court using this approach that may be somewhat more limited with a traditional midline subfrontal approach. Given a favorable third ventricular tumor located in the anterior aspect of the third ventricle and an expanded lamina terminalis, the translamina terminalis approach may be the ideal approach for a given tumor. The infratentorial supracerebellar approach takes the surgeon to the quadrigeminal cistern, pineal gland, and posterior third ventricle. At our institution, we rarely perform this operation in the sitting position unless dictated by the tentorial or venous anatomy. The concord positioning allows many of the benefits of the sitting position while still providing reasonable ergonomic positioning for the surgeon. Tumor displacement of local veins is important when choosing between this approach and the occipital transtentorial or posterior interhemispheric approaches. If the vein of Galen, internal cerebral veins, and basal veins of Rosenthal are displaced downwards and into the field, this approach may become very difficult to use given narrow operative corridors. The converse is true when these veins are displaced upwards and laterally, allowing for a favorative operative corridor to the posterior third ventricle. If an exophytic tumor in this region displaces the vein of Galen downwards, the internal cerebral veins laterally, it may be best approached from a posterior interhemispheric or occipital transtentorial approach. Transnasal approaches to ventricular tumors often rely heavily on the tumor to create the corridor into the third ventricle. Tumors arising from the third ventricle without exophytic components can be challenging to reach, even with removal of the tuberculum and planum sphenoidality and favorable location of the optic chiasm. Tumors that arise in the suprasellar space and extend into the third ventricle may be able to be followed into the ventricle for resection. Likewise, third ventricular tumors extending significantly into the suprasellar cisterns and displacing normal structures offer a corridor for removal. The transnasal approach is further limited in its ability to resect tumor that extends significantly lateral to the carotid arteries. A meticulous watertight dural closure given the high flow classification of CSF leak because of entry into the third ventricle. Inherent risks are related to the local anatomy and include visual, endocrinologic, and vascular injury. Entry into the fourth ventricle can be obtained primarily through the transvermian or telovelar approaches. These are described in more detail in the chapter. In cases where exophytic tumor extends into the region of the quadrigeminal cistern, approaches from above, including the supracerebellar infratentorial and occipital transtentorial approaches, may be considered.